And again, welcome everybody to the MSG Virtual Collaborative. We're going to be talking about diagnostics and updating invasive fungal infections. And we have a really, really interesting program today. As you can see here, we're going to briefly discuss our diagnostics survey that we did over the winter. We're going to talk about LFAs, candidate diagnostics, volatile organic compounds in medical mycology. Then we're going to have a break. Then we're going to go into new imaging technologies in mycology, molecular testing, and the challenge that we have with non-Aspergillus mold diagnostics. After that, we're going to have our breakouts with our sponsors where we get to interact with them and they get to ask us questions. We get to ask them questions again, and we'll be closing towards 1 p.m. Central. Again, the format is 20-minute discussions by the speakers, followed by 10 minutes Q&A. I'll be moderating the Q&A, and please do put your questions in the chat so we can look through them and go through them with the speakers. As I was mentioning, we did a survey over the winter. We were interested in seeing how our membership felt about the current status of diagnostics in mycology. And it's a pleasure to present some of the results that we have from the survey. This was sent to 692 members with a 38% response rate. We had 66 of the participants who identified themselves as clinicians. And our first question was, what fungal diagnostics do you currently use? And participants were able to select all that applied to them. About a third of them used culture diagnostics, 25% of them antigen testing, 17% of them antibody testing, 16% of them PCR. Very interestingly, 7% of them had access to next generation sequencing, and then we had others. As far as access, the question was, do you have access to a diagnostic solution other than culture for the following fungal diagnostics? And as you can see here, for a pan-fungal diagnostic, such as Fungitel, we had 40% of our participants said they regularly have access to it. 65% of them have regular access to Aspergillus testing. 33% of them had regular access to Candida. 27% of them regular access to coccidioides diagnostics, 62% for crypto, 40% for histoplasma, and for mucorales, 48% of the respondents have never had diagnostics or access to diagnostics for mucorales. And again, 48% of people reported regular access to PJP diagnostics. We ask, how strong is your need for an assay that provides genus and species for fungal results? And we did identify a very, very strong need for going to the species level, with 40% of respondents saying strong need, and 51% of respondents said definitely needed. And by importance, we ask people what is most important to them when we are dealing with fungal diagnostics, and the majority of respondents mentioned turnaround time being the top priority, access to susceptibility, 53% with second tier of priority, and cost was the least important of these three, with 53% of them actually mentioning that this is the third priority for testing. So as you can see here, there's definitely a lot of need for better diagnostics, and it is our pleasure to begin our seminar with all these questions to answer. I am going to start by introducing Maria Fernanda Gonzalez, who is joining us from Instituto Nacional de Ciencias, Médicas y Nutrición, Salvador, Zubirán in Mexico City. She is the head of the microbiology laboratory there, and she's going to talk to us about how lateral flow assays are changing medical mycology. Fernanda, you have the podium.
Good morning, everyone. And I want to thank the Mycosis Study Group and Dr. Luis Ostrosky for the opportunity to participate in this amazing symposium. I think that you just gave the perfect introduction. I would call it a desperate need for fungal diagnosis, particularly in low and middle income countries, as we will see through the following minutes. So during the following minutes, I'm going to try to describe the most relevant aspects of lateral flow assays and how they are changing clinical mycology. I have no conflict of interest regarding this topic. And as we all know here, one of the reasons that we are all together is because we all recognize that fungal diagnosis is quite a challenge. It definitely needs a high index of suspicion coming from properly trained physicians. It depends on appropriate sample collection at the bedside of the patient. It needs a very skilled laboratory personnel with training in mycology, particularly when conventional methods are used. Laboratories must have a very complex infrastructure with access to immunoassays with PCR capacity, and in some cases, ideally with biosafety levels 2 or 3, depending on the type of specimens that they handle. And all of this results in very high cost and definitely limited accessibility where these patients happen to be. Definitely, medicine is moving towards point-of-care testing, which are the tests that can be performed and read at the bedside of the patient. This kind of testing leads to expedited clinical action, and the objective, particularly today, is to improve the outcomes of invasive fungal infections. This type of technology is particularly suitable for low and middle-income countries, where actually the highest burden of the most lethal invasive fungal infections do occur. The World Health Organization has defined which criteria must be met in order for a test to be properly called as point-of-care testing. And this kind of testing must be affordable, sensitive, specific, user-friendly, rapid, robust, and as equipment-free as they can be. And talking about cryptococcal meningitis, this is the most because meningitis advanced HIV leading to HIV-related mortality, and it represents 15% of all data nowadays. The majority of those cases do occur in low and middle-income countries, where reality, where real-life scenarios approach 50% mortality. The stage for diagnosis for this condition is the detection of cryptococcal by.
Fernanda, I'm sorry, we're having trouble hearing you. Maybe we're having a bandwidth issue. Can you try to turn off your camera and see if we get better sound?
Okay. Is it better now?
Yes. Go ahead.
Oh, okay, perfect. So, the main for cryptococcal meningitis diagnosis is the detection of cryptococcal antigen by latent or enzyme immunoassays. These tests are pretty much sensitive and specific, but they do depend on having proper laboratory conditions, such as skilled laboratory workers, steady electricity, heat inactivation processes, cold chain shipping processes, because they require refrigeration of reagents. And then again, this might not be the case for low and middle income countries. This is why one of the first flow assays, actually the cryptococcal antigen. This test was one of these tests was developed by Diagnostics. It is not the only one. There are several others lateral flow assays, and they all have equally good performance. However, many of the others are less validated and maybe less specific. One of the most attractive characteristics of this test is that it has a lower limit of detection compared to latex agglutination testing, which results in higher CSF titers when using the lateral flow assay. This test has been approved for serum, plasma, and CSF testing. It is approved in this type of samples. However, it has also been studied in urine, where even though levels are pretty much reduced, it is still sensitive for the detection for active cryptococcal meningitis. This kind of testing has also been studied in fingerstick sampling, where it is also reliable for active cryptococcal meningitis diagnosis, but it is definitely not sensitive enough for asymptomatic screening. And all of these LFA technologies are pretty simple to perform in the laboratory. As you can see in the figure, the sample is mixed with a diluent, and after, in this case, 10-minute incubation, you can have the result at the bedside of the patient. And definitely this does not require any laboratory information. One of the other characteristics of this kind of testing is the low costs, which in this case, IMI Diagnosis has lower cost for low and middle income countries. Nowadays, as you can see in this figure, the LFA cryptococcal antigen testing is considered the most sensitive test, even to agglutination testing. And this has many countries to define and implement screening for cryptococcal meningitis. In kind of testing has allowed us to define the prevalence of asymptomatic cryptococcal antigenemia. It is estimated a global prevalence of 6% when testing people below 100 CD4s. But this prevalence is definitely varies within geographic regions. As you can see, in North America, the prevalence may be the lowest, as low as 3%, whereas in South Africa or Cambodia, the prevalence can be quite elevated. Importance of testing and identifying cryptococcal antigenemia, it's that we know that it is a precursor of symptomatic meningitis. Up to 40% of all patients with cryptococcal antigenemia baseline do develop cryptococcal meningitis within a year with pretty good sensitivity. And it is also a independent predictor of increased mortality after antiretroviral therapy initiation. As you can see in this figure, the higher the titer, the lower the survival. And titers over 160 are those predictive of meningitis development. And titers over 640 are those predictive of mortality. So the LFA implementation is definitely practice changing because it allows to screen in low and middle income countries for this condition. It is actually recommended by the WHO and guidelines and several national guidelines because it allows to stratify those individuals with cryptococcal antigenemia that maybe ideally all of them should be performed a lumbar puncture. However, ideally, one should measure the opening pressure on the index lumbar puncture. However, in low and middle income countries, those manometers may not be available at the bedside. So if baseline that a patient has a cryptococcal antigenemia, a simple procedure such as empiric CSF drainage may result in a life-saving strategy. This strategy has been proven to be cost-effective in countries around 8%. You need to test 11 patients in order to prevent a case, if you can treat early to prevent a case of meningitis, and you need to test 16 individuals in order to prevent one death. This is how several guidelines nowadays, guidelines in North America do recommend to test and to treat with preemptive fluconazole treatment below 100 CD4s, the same strong recommendation by the latest WHO guidelines. And although the optimal treatment is yet to be determined, whenever you only have access to LFA titers, you can select one of the recommended fluconazole preemptive treatment schemes. And whenever you have increased LFA titers, you should assume cryptococcal meningitis is involved and treat accordingly. These strategies have the potential to reduce mortality. Several studies reduce mortality with preemptive fluconazole treatment, although this has been kind of inconsistent among I'm switching to disseminated histoplasmosis. This is another life-threatening AIDS-defining opportunistic infection. The annual incidence in endemic region is estimated at 5%, and increased mortality is still the case despite optimal antifungal treatment. Recently, epidemiology has been changing with increasing reports outside endemic regions. And this is particularly the case for Latin America and Sub-Saharan Africa, where histoplasmosis has remained as an invisible burden, mainly because the lack of available commercial antigen testing. As you may this recent report at the Lancet, it is a modeling study which identified several hotspots for regions in Central and South America where the incidence of disseminated histoplasmosis among people living with HIV may even surpass that of tuberculosis. That is really relevant. However, widespread diagnostic availability is the main challenge. As Ostrosky showed us in his introduction, in this Manaus Declaration, 43% of all Latin American countries said they had access to antigen testing, which is quite similar to what Dr. Ostrosky showed us. Whenever it is coupled with molecular testing, the 65% of at least the countries that attended the meeting have access to this kind of technology. And one of the problems is that the minority of the countries in Latin America have histoplasmosis as a reportable disease. So this results in that we are basing our diagnosis in traditional methods, which we all know that cultures around times over 2 weeks, which results in many patients are still dying before the diagnosis can be made. Antigen testing was developed by Miravista Diagnostics since the 80s and has been improved ever since. It was until recently the only antigen testing for urine testing. However, they have also developed a novel lateral flow assay, which might actually become the game changer for histoplasmosis across the globe. This test has a turnaround time of 40. Has been CE marked, but not yet FDA cleared. Another test, which is not a lateral flow assay, but which is also been developed by IMI Diagnosis, is another antigen test, but it depends on enzyme immunoassays, which is a disadvantage when this kind of testing are performed as batch testing in reference laboratories. So this is another advantage for the LFA that can be performed as single testing. And this may be the case for the first point-of-care test for histoplasmosis. This LFA has been evaluated in several studies. One of these was a case in a study in Mexico, actually here at the microlab, where it was tested in almost 400 samples from patients with suspected disseminated histoplasmosis. This test had pretty good sensitivities and specificities, but it a very dramatic prevalence of histoplasmosis of 26%, which actually surpassed those of mycobacterial infections in people living with HIV, which was information we did not previously have in the country. This test has also been evaluated in samples from Colombia, where they tested, where they compared the novel LFA versus the traditional enzyme immunoassay testing. In this they found a comparable sensitivities, but increased specificity for the case of the novel LFA. Also, another study, which was performed at Miravista Diagnostics, this particular study included a wider presentation of hosts and disease severity. And in this study, although the overall sensitivity for the LFA was compared to the enzyme immunoassay, when the subgroup of immunocompromised patients and disseminated cases was analyzed, comparable sensitivity was found. So and it is expected to have a reduced sensitivity in compromised patient tests. Switching to coccidioidomycosis, this disease has also been described with rising incidence in endemic and non-endemic zones. And the definition of the current endemic zones is limited mainly because of the lack of diagnostic tests outside endemic regions. One of the consequences of this is that treating coccidioidal pneumonia with antimicrobial treatment leads to unnecessary treatment and increasing healthcare costs. The mainstay for diagnosis condition is still based on enzyme immunoassays and serologic assays in endemic zones. However, this type of testing has turnaround times between 5 and 10 days in the case for serology. In the case of laboratories handling cultures for coccidioides, this should be done in facilities with biosafety level 3, which also limits diagnosis for conventional laboratories. A lateral flow assay has been developed by IMI Diagnosis to identify coccidioidal pneumonia. It has been FDA approved and it has a turnaround. There are several studies that have evaluated this LFA test. The first two studies were performed on the frozen serum samples from endemic zones, one in California and another in Phoenix, and they both found sensitivity and specificity. Also, they showed a dramatic cost reduction when using this kind of testing compared to conventional serology. However, another study made a prospective validation in patients going into the emergency department in Arizona with suspected coccidioidal pneumonia. And in this case, sensitivity was reduced, probably because those were cases of earlier in at the time of presentation compared to previous studies. However, more studies are needed to clarify the role of this LFA. This assay has also to identify coccidioidal meningitis. This was tested on CSF from patients with suspected coccidioidal meningitis, and this has a very good performance with sensitivity and specificity compared to conventional serologies. And last but not least, several LFAs have been developed for Aspergillus diagnosis. The current standard for invasive aspergillosis is galactomannan testing by the enzyme immunoassay by Platilia. And although PCR and molecular technologies are reasonable alternatives, they are not yet fully standardized, although they are recommended by international guidelines for diagnosis. One of these lateral flow testing has been developed by IMI Diagnosis. It targets the same antigen used as the Platilia assay. It has a turnaround time of 45 minutes. It is recommended to be performed in serum and BAL samples, require a step pretreatment of these samples by heat and centrifuging. Implemented a digital reader that increases sensitivity and specificity, and several studies have evaluated the performance of this test and found sensitivities and specificities which are comparable to conventional galactomannan testing. It is not the only lateral flow. There are many others. This is the case for the LFD, which is a different antibody. This has been CE marked for serum BAL testing. Turnaround time of 15 minutes. When it is increased to 30 minutes, it can be improving sensitivity and several studies have compared both of these LFAs. This is the case of this study done at Belgium and the Netherlands. This was performed on frozen BALs, and it was compared to the definition of proven and probable invasive aspergillosis by the conventional criteria. One of the main findings of this study is that actually there was a 20% disagreement compared to the LFD, and maybe because target as galactomannan, which has comparable sensitivity to this testing. When testing serum samples with these LFAs, meta-analysis have shown comparable sensitivity of the LFA to conventional galactomannan. This study, which evaluated both LFAs in high-risk hematological patients, identified also increased sensitivity for the LFA compared to, but actually the better combination was the use of beta-glucan testing combined with LFA, which achieved sensitivity to galactomannan serum testing. And there is another LFA modality which is very attractive because it involves urine testing. It is another lateral flow assay, which has a turnaround time of 30 minutes. It allows semi-quantitative reading, and this has been studied in a single study, which was a proof of concept, but it revealed that it had a moderate sensitivity and specificity, which makes it a potential point-of-care test to screen patients at risk. Let's see how this develops. Other scenarios for LFAs regarding aspergillosis is chronic aspergillosis. There is another LFA, which was to conventional serology for identification of chronic aspergillosis, which we know it's also an enormous burden in low and middle income countries. And these have found pretty good sensitivities and specificities, which is the ideal setting for this condition in low and middle income countries. The IMI diagnosis has also been tested in critically ill patients with suspected invasive pulmonary aspergillosis. When used the specific criteria for critically ill patients, it has a very good sensitivity and specificity, which may make it a good alternative for the diagnosis of critically ill patients. Regarding COVID-associated pulmonary aspergillosis, we did an exploratory study here in Mexico City, where we tried to validate the use of galactomannan and the LFA in tracheal aspirate samples, which we know it's not a recommended type of sample, but because of limited access to bronchoscopy, this may result in sometimes only available sample. And we found moderate sensitivity with high negative predictive values when using increased cutoff for this kind of testing, which must be also replicated in other studies before implementing it. Take-home messages, we have found that fungal LFAs are true point-of-care tests that are coming of age. They contribute to the changing epidemiology in fungal infection landscapes. They will allow us to better define the endemic regions for many of these fungal infections. They allow us to understand the natural history, for example, asymptomatic cryptococcal antigenemia, and they allow early screening interventions with preemptive treatment, which actually impact on mortality. They sampling in the case for urine testing, as we have described. One of the biggest advantage of this kind of testing is that it allows single testing compared to batch testing, as usually performed with enzyme immunoassays. This kind of testing has shorter turnaround times, which may lead to earlier fungal treatment. However, we are still in a desperate need for widespread availability of all these kind of technologies. Thank you very much for your attention, and I'll be happy to take any question.
Thank you very much, Dr. Gonzalez. We have a question from Dr. Shanda, who wants you to maybe go in a little bit deeper about the sensitivity and specificity of the crypto LFA according to CD4 counts.
Okay, the crypto LFA and CD4. Okay, so where the burden of cryptococcal meningitis is significantly more prevalent when reduced CD4 counts. In order for this strategy to be cost effective, it depends on the prevalence of the disease. So where it is recommended by consensus of international guidelines to screen for cryptococcal antigenemia below 100 CD4 counts. This is mainly because of the prevalence of the disease.
Great. We also have another question from Dr. Shanda, who's asking you to please enumerate the causes of false positives in galactomannan.
Okay, so galactomannan has several false positives. One of those, when thinking about diagnosis, one of the false positives are other fungal infections, for example, histoplasmosis, for example, Mycelium in some cases. Much has been described regarding use, and which has been the case for specific lots of piptasa, for example, but it's not the routine false positive. So mainly other fungal infections which can give false positive for this kind of testings.
Very good. We have a comment and a question from Paul Eder, who's saying, to understand the low sensitivities in many of these tests, it would be helpful to know the typical titers of these pathogens in CSF or in circulation. Do you think they're so low that the only reliable way to detect them is with amplification, i.e. a molecular test?
Well, that is a very good question. I'm not aware that there is any PCR indicated, for example, for cryptococcus for serum. However, as low the titers, even the lowest titers do have natural history with increased mortality with any kind of with any titer as low as 1 to 2. So these patients need specific evaluations and careful evaluations.
Perfect. We have a question from Dr. Chaturvedi in New York. He's asking your opinion on LFAs for Candida. Have you heard of any of those?
I am not aware that there is any. I wouldn't be surprised if they in the near future, and I hope that we get them, but I'm not aware of any of those.
Okay, and we have Dr. Marcio Nucci, who's asking any data on LFA for Aspergillus as a predictor of outcome.
Okay, so there are when the LFA performed in a quantitative way, the titers can be predictive of outcome. However, the follow-up has not been proven to behave as galactomannan. The persistence of positivity has not been translated into an adverse outcome, although the initial titer might have an impact on the outcome.
And along those same lines, we have Dr. Gupta asking any comment on the role of LFAs in the treatment monitoring of cryptococcosis.
Okay, so as it is the case with agglutination, which is not predictive during follow-up, it is not recommended to perform additional testing in a patient who has already been diagnosed with meningitis, because it does translate into an adverse outcome.
Very good. We have a comment from Dr. White, who's saying that they have found that false positive Biorad galactomannan on BAL fluid can be identified by performing a secondary lateral flow. Do you have any experience in doing that, multiple testing to sort out false positives and false negatives?
Well, there are several studies which evaluate combining, for example, galactomannan or galactomannan with the LFAs, and they can in fact increase sensitivity but also specificity when both tests are positive. Single test is positive. That's what may increase specificity and reduce false positive.
And the final question from Dr. Sulaiman. How do we analyze the LFA galactomannan optical density to that of IPA and kappa? Does it correlate with the ELISA optical density?
Okay, so need the digital cube by IMI diagnosis that can give quantitative titer, and it does correlate with the galactomannan titer by ELISA. Yes, but the digital reader is needed for that.
Very good. That's all the time we have for questions. Thank you so much for this interesting discussion on LFAs.